the...
More people waiting. That's a good thing.
Good evening. Hi, I'm Garrigues. I'm an orthopedic surgeon specializing in shoulder and elbow at Midwest Orthopedics at Rush. I'd like to welcome you all to YouTube Live. It's our first inaugural Midwest Orthopedics at Rush Meet the Physician YouTube Live interactive discussion. So I appreciate everybody that's joining the discussion tonight. I look forward to answering all of your questions. We've got a team here who's going to field the questions and read them off to me, and then hopefully I can answer all of your burning thoughts about shoulder, elbow, operative, non-operative treatment, surgeries, anything that's on your mind. Happy to answer it. So by way of introduction, a word about me. Again, my name is Garrigues. You can visit my website, drgshoulder.com, drgshoulder.com. I did my training at Harvard, Duke, and the Rothman Institute. I specialize in shoulder and elbow surgery. That involves really anything that affects the shoulder and elbow. So that's a lot of sports injuries, as you can imagine. It's also degenerative conditions like arthritis and traumatic conditions like fractures. So we do a lot of minimally invasive arthroscopic surgery like rotator cuff repairs or labral repairs, but we also do big reconstructive procedures just depending on what the pathology is. So we're anatomically very focused, but in terms of the pathologies we treat, the ages of the patient and the conditions, it's as wide as you can imagine. So really any condition that affects the shoulder and elbow is something that I would see. And the nice thing about being here at Midwest Orthopedics at Rush is that I have a whole team of colleagues in orthopedics, but also in the allied fields that we can work with and get imaging or work on physical therapy, testing, motion analysis and throwing analysis, et cetera, et cetera. We really can lean on all the resources here of Rush and Midwest Orthopedics at Rush. So that's a word about me. I'd love to get to the questions. Why don't we start out with a common one here? So a lot of people ask me, what is the rotator cuff? This is a very common thing, probably one of the most common things that we see in the shoulder clinic. The rotator cuff is a series of 4 muscles and tendons, and I have this handy dandy model here we can use. So this is the shoulder blade, the collarbone or clavicle, and then the humerus or arm bone. So this would be a right shoulder just like this. So first of all, you can see that the shoulder is not just one joint. It's not just the ball and socket joint. It has this joint here where the collarbone meets the shoulder blade. That's called the AC joint. It does have the ball and socket joint. It also has the joint where the shoulder blade meets the rib cage. So it's multiple joints working in concert. The rotator cuff, as I mentioned, are a series of muscles that surround this shoulder blade. They take their origin from the shoulder blade. They attach around the ball here. It basically helps stabilize the ball and help it move through space. So the humeral head, if you will, the ball at the top of the ball and socket joint, moves with these rotator cuffs. So the supraspinatus tendon is the rotator cuff tendon on the top. It is the most commonly torn rotator cuff tendon. There's a lot of reasons why that might be. That's commonly debated. One possible thing is it kind of goes through this bony arch and then the bony part of the proximal humerus. So it's constantly kind of under stress and strain. Another reason is that it has a very poor blood supply. So the area where the tears begin has a very limited blood supply. Why is that? Well, because it needs so much connective tissue to be so strong. There's really not a lot of room for extra blood vessels. That limited blood supply does prune back with age and also with disease. So things like smoking, diabetes, high cholesterol can affect the blood supply to the rotator cuff and lead to premature rotator cuff failure. The other reason why it might tear is that it's the only tendon in the body that is fully stretched out and it's resting tension. So other muscles kind of have if you think of your forearm muscles, they can get shorter or longer depending on how you bend and straighten your wrist. The rotator cuff itself is always under its full tension if your arm is at your side. So the number of reasons why it could tear, the bottom line is it typically does. Age is the number 1 risk factor that leads to rotator cuff tears. Another question that comes up a lot is, I'm a 65-year-old golfer. How could I have a rotator cuff tear? I thought that was something only baseball players get. Well, we deal with baseball players. I'm one of the co-team physicians for the White Sox and the Chicago Bulls. And so we see the rotator cuff tears the baseball players get. They're a very different scenario. That's a very small part of the pie. Basically, in the extreme positions that a baseball player will put themselves in during a baseball pitch, the underside of the rotator cuff can basically rub on the back of the socket, and that can cause some fraying of the rotator cuff. Very different than what I described as far as the age-related changes that weaken the rotator cuff over time. So most rotator cuff tears happen with age, but also with some trauma. So the trauma can be a small thing like reaching in the back seat and picking up your purse, your briefcase. It can also be playing golf, tennis, et cetera, et cetera. These things can kind of act upon a tendon that's a little bit weakened and cause the tear. Another question we have is surgery always the answer for the rotator cuff? And the answer is absolutely not. So many people have rotator cuff tears and have no symptoms at all. The reason is there are 4 rotator cuff tendons. They work in concert. So you can have a small tear in one of the tendons, even a full thickness tear or certainly a partial tear. And if the other muscles and tendons are working well, the patient will have no idea they even have a rotator cuff tear at all. Our goal initially is to turn a symptomatic rotator cuff tear into an asymptomatic rotator cuff tear. And certainly with the partial thickness ones, we can do that with a high degree of success. That typically involves an injection, physical therapy. And if the patients don't get better, only then do we talk about potentially getting imaging, MRI, and then potentially surgery if they're not improving with the non-operative measures. Another question that comes up a lot is how do we actually repair the rotator cuff? So it used to be done with a big open incision on top of the shoulder, taking down this very important deltoid muscle, splitting that, and then hoping you get a good repair on the way in. Now we do it typically with a minimally invasive surgery. So we use a tiny fiber optic camera the size of a pencil, put that in the shoulder, and we can look all around at the shoulder while we're watching the surgery on a TV. We inflate the shoulder with water, and then we can use very specialized instrumentation to put tiny little anchors. They're about 4 to 5 millimeters in diameter in the humerus and the ball part of the bone. These are made typically out of a composite material that becomes bone over time. So there's no metal used typically. Those have thread that comes up out of it. We use that thread to then tie the rotator cuff back down to where it is supposed to attach. After that, the patients use a sling for a period of time, typically 6 weeks, sometimes 4 if it's a smaller tear, and we allow the rotator cuff to heal. During that time, things are healing. They're doing physical therapy to avoid stiffness, and then eventually we expect a full recovery. It's an operation that's highly predictable, and in the right hands with the right therapist and with a motivated patient, that has a high degree of success. So see if we have any other questions here from Facebook Live. Another question is about total shoulder replacements. People are saying, listen, I have a lot of friends with hip and knee replacements, and I've never heard of a total shoulder replacement. We get that a lot in our clinic. It's very common in our clinic because we do hundreds of them a year, but it's uncommon in general population. So for example, there are about 1.5 million hip and knee replacements, and it's rising every year, done annually every year in the US. And there's about 100,000 total shoulder replacements. So it's literally orders of magnitude less common. A lot of years ago in the 1970s, shoulder replacements did not work very well. The current shoulder replacements we have work essentially just as well as hip and knee replacements. They last just as long. In high volume centers, such as our group here at Midwest Orthopedics at Rush, the results are, again, just as good as hip and knee replacements. So we've got a question here from Devin. What are the most common causes of shoulder pain? Great question, Devin. I'm glad you asked it. So the most common cause we call bursitis. So bursitis is inflammation of this fluid-filled sac. So bursa is Latin for sac, that basically lubricates between this bony arch of the shoulder, which is right here on top, and the rotator cuff underneath. So what can happen is if you get basically a little weakness in the rotator cuff, a little inflammation starts from a trauma, maybe your shoulder blade posture is not ideal and it's causing this arch to close down because some of your postural muscles are not allowing you to keep this arch wide open. Those things start a kind of a vicious cycle where you'll get basically irritation on the rotator cuff. So bursitis is commonly known as rotator cuff tendonitis, same thing. That pain in the shoulder makes you use your shoulder a little bit less. When you use it a little less, the muscles become weaker and less coordinated. Then the pain gets worse. You use it a little bit less. You get in this vicious cycle. The way to break that cycle is number one, avoidance. So a lot of these start with some strenuous overhead activity. So people come in, they've just painted their ceiling or done a lot of swimming that they hadn't done before, hadn't ramped it up carefully. The second thing is, again, a careful physical exam and then often an injection and physical therapy. The goal of physical therapy is to improve the muscle balance, so the muscles in the front that pull the shoulder blade down and the muscles in the back that pull the shoulder blade up and open up this space are well balanced. It also improves the anterior and posterior force couples of the rotator cuff. This helps pull the ball down and keep it from riding up. Again, we're trying to prevent friction in this location up here at the top of the shoulder. So that's kind of the key thing. That's definitely the A1A number one thing we see in our clinic. We also see a lot of arthritis, rotator cuff instability, fractures, collarbone injuries, etc. But that is the number one by far. We've got another question here. Can I play through pain? This is coming in from Ann. Ann, great question. The answer is yes and no. So there's different types of pain, and I think it's always hard when we're doing an athletic endeavor to know, listen, am I just having pain because I'm pushing my body to the limit? The so-called good pain of I'm working out my muscles, I'm working out my joints, I'm doing something that's gonna make me stronger, or have I gone into the point where I'm really doing damage to myself that it's not going to improve my long-term health? Obviously, if we're working out, if we're playing a sport, our goal is to constantly improve. We don't want to get in a scenario where we're injuring ourselves and getting worse. I think the key thing there is the trajectory over time. So if you're having pain while you're doing activities such as golf, it may not be a big deal, but if that pain persists, so if you're having pain the next day after you're in the gym, the next day after you were playing tennis, the next day after golf, that's a concern. And typically, if it goes for more than 48 hours, it's something I'd be very concerned about. Certain types of pain can also be very concerning, very sharp pain during the activity. So I think people that do a lot of athletics are familiar with kind of the stiffness and soreness versus kind of a sharp pain. The sharp pain is more concerning. There are multiple studies in throwing athletes, certainly in the baseball world, that if you are pitching with shoulder and or elbow pain, you are at higher risk for injury. So if it's during a very intense sport like baseball, definitely do not want you playing in pain. If it's a little pain in your joints after a particularly aggressive weightlifting session, that may be okay as long as it goes away in a day or two. So definitely we recommend a little bit of rest, a little bit of ice, maybe an anti-inflammatory as long as you don't have medical conditions that prohibit that. But if it doesn't get better, give us a call here at Rush. Another question here. This is from Allie. How do I know if my pain is doctor worthy? Great question. So we alluded to that a little bit, but basically give it a little time. We're happy to see you at the drop of a hat. So if your pain is so bad that you are thinking, listen, it's causing me, I can't sleep, I'm considering having to go to the ER, definitely, we want to hear about that. We also respect the mechanism. If you were in a car wreck, you fell down the stairs, a serious high energy trauma, again, that's going to be pain that is going to have a higher chance of being something that could be problematic that you're going to want to seek out a physician advice. If it's a slow, nagging thing that comes on only during strenuous activity and then goes away, you may want to give it a day before you come see us. But again, we're here for you. We have multiple clinic locations throughout Chicagoland. We also have telehealth options for those who are out of state or even out of the country. So, we want to hear about it. If you're having a problem and if you in your own mind think this is concerning enough to you that you'd like to talk to us, then we'd love to hear from you. If it's only reassurance that we're providing, even that can be a service to many people and help them get on with their activities. Next question from Andrea. How safe is in quotes here, is CrossFit for shoulders? That's a great question. So as a shoulder surgeon, we see these kind of spikes. So for those who are listening who are old enough to remember the P90X craze, we saw a huge uptick in shoulder after that. That was probably a really tough one because it was a defined 90-day, extremely strenuous upper body workout. And there was absolutely nothing wrong with the majority of the exercises. It's just the idea of ramping up that quickly. So people used it. Hey, listen, I've got a big event coming up. I'm going to be in a wedding or something, and they would just really, really hit their bodies hard. And the problem is there was no time to recover. So if you started out on the wrong foot and you had a little nagging injury, you've committed to those 90 days, and you're doing that through. So that one we saw a lot of injuries from. CrossFit, we see fewer injuries. I think part of that is part of the focus of CrossFit is really on doing the exercises in a proper form, as opposed to just kind of powering through. And I think that's a healthy focus, a healthy part of CrossFit. Also, CrossFit, you're more in a community setting with other people as opposed to, kind of being in front of your TV doing your P90X workout. So again, working out is great. We want to encourage people to reach their full potential. But CrossFit, you got to make sure you're doing the lifts properly. You want to make sure you're balancing pushes and pulls. You want to make sure that really, you can hurt yourself with those if you don't have the proper form. So just like anything else in life, you got to make sure you're learning it properly. Start small. Don't bite off more than you can chew, and ramp up. Get the form down first, and then work for the strength and endurance. Another question here. Can't move your arm above your shoulder. Is that frozen? What to do? So frozen shoulder is a common thing we see. So frozen shoulder is also known as adhesive capsulitis. This is a very common condition. Multiple risk factors, all of them very common. So diabetes, or any whiff of diabetes, pre-diabetes, family history of diabetes, borderline diabetes, any of those things could be a predisposing factor. Menopause, thyroid disease, either low or high, and then trauma. So it can be a minor trauma, like you kind of grab something funny or your dog leash pulls in you. It can be a major trauma, like a surgery or a fall or a fracture. Any of those things or none of those things can lead to adhesive capsulitis. The shoulder joint becomes very inflamed. That inflammation leads to scarring and thickening. And you can imagine if this part of the joint capsule, the joint line becomes thickened, it's going to tether your movement. The earliest sign is typically patients will have difficulty reaching behind their back. For our female patients, often they complain with difficulty fastening their bra. And so frozen shoulder definitely will cause limited range of motion. There are other reasons you may not be able to raise your shoulder. It may not be a mobility problem. It may be a motor problem. In other words, if you have a rotator cuff tear where the shoulder moves just fine if I use the other arm to move it, but I can't get the power to do it, that may be a sign that some of your rotator cuff tendons are no longer attached, and so you don't really have the power to move your arm. The bottom line is we see patients for pain as the number one complaint, but it's also loss of motion. It's also instability, the shoulder popping on a joint. It's also weakness. So other shoulder complaints beyond pain are absolutely something that you want to seek out a medical opinion for. Another question here from Samantha. Are there non-surgical options for shoulder arthritis? Great question. I'm glad you brought that up, Samantha. Definitely there are non-surgical options for whatever we do. So people sometimes are a little bit hesitant to see an orthopedic surgeon. They think we're going to pounce on them with a scalpel or something. That's not how it works. We are trained fully in non-operative and operative treatment. So I myself have a conservative philosophy. I like to treat every patient like a family member. So just like I wouldn't pounce on my own family members for surgery right away, I would say, listen, let's try non-operative measures. Let's try medical modalities, maybe an injection, et cetera, before using surgery as a last resort. And I treat my patients the same way. So, for us, injections, ultrasound guided injections, even biologics, things like PRPs are part of platelet-rich plasma. They can have a healing effect or part of our treatment options. And then we work very closely with our physical therapy group here at Midwest Orthopedics and beyond. That goes for shoulder arthritis. That also goes for all the other conditions I mentioned. So with regard specifically to shoulder arthritis, there's a big jump. So the non-operative things are anti-inflammatories. Stretching, I believe, can be helpful if it's gentle and done frequently. And then cortisone injections can be very helpful. Then there are some minimally invasive treatment options for certain patient populations. And then it's a big jump to something like shoulder replacement. Yes, there are non-operative treatment options, and we want to make sure that we maximize those before we move to something more definitive. Perfect. So listen, I know there's other questions, and I'm sorry we're short on time, but I want to thank everyone for joining us tonight. Again, my name is Grant Garrigues. You can visit my website, www.drgshoulder.com, drgshoulder.com. Please do not hesitate to reach out to us here at Midwest Orthopedics at Rush. We love to see you. The best part of my job is meeting patients of all walks of life, all ages, all different hobbies, vocations, et cetera, and then getting them from a state of ill health to a state of health where they're happy at the end. So please consider us if you have any shoulder problems. Don't hesitate to call me at 312-432-2880 or visit our website for more information. Thank you so much for your attention tonight.